Thank you all for joining our Patient Partnership Week event around empowering patients as partners in their equal care. I'm Rachel, I'm the Chief Executive of the Patient Association, and I'm going to be chairing this event. So this morning we have with us Haris and Dr. Dan Degerman, and Dan, I'm just going to ask you to introduce yourself first.
Sure, thank you. So my name is Dan. I'm a research fellow at the University of Bristol, specifically in the philosophy department. And my work focuses on what we'll be discussing today, namely epistemic injustice. Yeah, and I think we can start like that.
And thank you so much for coming. And Haris, it's the middle of the night for you at the moment, but thank you for joining us.
Good morning, everyone. I'm in New York, so it's the middle of the night. My name's Haris Sultan. I used to be the non-exec responsible for Citizens and Future Generations on West Yorkshire ICB. And that really meant we had a non-exec lead responsible for ensuring the voice of the patient was central to the board's working, as we realised that is something that we often forget to do on NHS boards. And I started my whole journey in healthcare as a patient, but also as a patient advocate, setting up the youth board at Leeds Community Healthcare Trust to ensure that we actually hear the voice of patients in all the work we do in the NHS. Because I realised the one voice we often don't hear is a young person's voice. So I'm really excited to be here to discuss this topic because it's definitely worth getting up at 4 a.m. for.
Thank you so much, Haris, and it's great to see you again. So, Dan, I'm going to hand over to you first of all, and help us understand what is epistemic injustice.
Sure. So epistemic injustice is a tricky sounding word, right? So epistemic refers to this branch of philosophy that's concerned with knowledge. And what epistemic injustice means, what it refers to are injustices committed against people specifically in their capacity as knowers. What does that mean? So it's basically concerning people's ability to obtain knowledge, maintain knowledge, and to share knowledge, right?
Mm-hmm.
And one way to grasp this is by thinking about the two main types of epistemic injustice that the concept's progenitor or author, Miranda Fricker, named when she came up with this in 2007, or when she wrote about it in her book in 2007. So the first of these epistemic injustices is something called testimonial injustice. And I hope this is something that you might recognize, or well, hopefully not too much from your own life. So this refers to a situation in which a person's testimony, what they're telling someone else, is downgraded by the person listening to them for unwarranted reasons, right? So we can think here, for example, of someone who goes to their doctor and complains about feeling really hopeless and horribly sad and like nothing matters anymore. But say this person is a woman and the doctor is a misogynist, or at least has some misogynistic biases. And they're thinking, right, well, women are overly emotional. I'm sure this person is too. So they might tell this person who's come in that, well, I think this is just you experiencing the normal ups and downs of life. So how about you go home, you chat to your husband, and things will feel better, right? Can think of a similar sort of example, but slightly different. If we imagine someone who has gotten a diagnosis of depression, who might maybe tell their partner that, oh, I feel like my boss at work isn't treating me well, and it's making me feel really bad. But say the partner, knowing that their partner has depression, thinks, well, or maybe tells them, well, this might just be your depression speaking. I'm sure everything is actually fine. So that's testimonial injustice. The other main type of epistemic injustice is slightly trickier, but it's really important. It's called hermeneutic injustice. And this refers to the sort of injustice or the sort of harm that comes from a person finding themselves in a situation, often because of their identity, where they lack the resources, like the words or the stories or the relationships that allow them to make sense of some part of their experiences. and or to share that experience with other people. Here we can again, I think, use depression as an example, because we can imagine maybe a time or just a part of society where depression just isn't an available concept, something we can use to describe this intense experience of hopelessness. And if that's not possible, what happens when I try to tell people that I'm suffering from this horrible sense of hopelessness? Well, they'll probably respond to me that, well, you probably just need to pull yourself up by your bootstraps and get on with your life, right? Um, so that is epistemic injustice in a nutshell. And I think you're probably already able to see how serious the consequence of this might be, right? It can lead to a loss of knowledge, particularly in healthcare situations when there's a loss of knowledge. There might be serious harm to people's bodies and minds. There might even be death. And of course, there are all these kind of psychological implications of experiencing epistemic injustice as well, right? So if someone is consistently downgrading what we tell them, well, we might just stop talking, right? And I don't want to go on for too long, but maybe just touch briefly on some or outline some of the routes we might take or some of the ways we might think about addressing epistemic injustice. And these, I think, really align with the patient association's approach to its objectives, right? So on the one hand, I think it's important to think about addressing epistemic injustice, which is often related to bias, right? It's important to try to address that on the individual level. And the most obvious site where we'd start with that is with the healthcare professionals, right? One thing that we might think about is how we can kind of teach medical professionals to practice more epistemic humility. What does that mean? Well, basically, just being more open to the possibility that your knowledge isn't complete and you need patients to complement your knowledge. We can also talk about the patient and family side later. But then I also want to mention the structural side, right? Because a lot of biases are there implicitly in a way that it's not easy for individuals themselves to address them. So we need to also think about what kind of institutional changes we can make. How can we make processes within the NHS easier to understand and create them in a way that can maybe ameliorate the biases that are already there. And of course, then there's a political level and the social level. Now I've talked for a really long time, so I want to.
No, you haven't, and it's really it's just so interesting. But I have lots of questions, and I'm seeing questions are already going into the Q&A. But I'm going to come to Haris, and Haris, I'm going to ask you for your reflection on what you've heard, maybe in line with some of your experiences.
So, totally agree with everything Dan said, and I think it's really important to think of the examples. Like Dan talked about mental health patients and patients with depression, but if we think about it, particularly students, they might report mental health symptoms, but they're often very easily dismissed or told they're overreacting because stress is part of. We're always told now stress is part of being a normal teenager. So you're just stressed rather than receive, and it's just normal rather than receiving a proper assessment. I also sit on the National Children and Young People's board for NHS England, and something we've discussed there is autism, because we always look at why are boys more often diagnosed with autism than girls. It's because girls who exhibit features of autism are often misdiagnosed or not diagnosed properly because all their behaviours don't match the typical stereotypes that which are typically displayed by their male counterparts. And things like people like LGBT individuals, they might not be believed or have their concerns minimized when discussing health issues relating to their gender identity, because the attitudes towards transgender individuals who seek hormone therapy and gender affirming surgery in the UK are differ massively between healthcare professionals. The NHS Youth Forum a few years ago did a project on transgender and non-binary access to healthcare, which is an amazing piece of work. And the final thing I'd just like to touch on is when Dan said about epistemic humility and educating healthcare professionals. So I did a project a few years ago with the leading a project on health inequalities, and we asked one question to around over 1,000 medical students in the UK of, do you understand health inequalities? And do you know you're actually required by the GMC in Outcomes for Graduates, which is the document that says, by the end of your medical degree, this is what you have to be able to do. So we asked them, do you know that you actually need to be knowledgeable at healthcare inequalities? And 80% of them didn't know that. So I think when you look at the root of the issue and where the root of the cause of this epistemic injustice is, it's really in education. We're starting to make these solid leaps and bounds. I'm also a medical student as well, so I've been through system and I've seen the type of teaching we get. But when we look at it, we have our odd sessions on this is what inequalities are, this is what injustices in the healthcare system, these are your microaggressions. But really, how much does a multi-choice questionnaire on microaggressions really iron them out?
Yeah.
It's things like that we need to think about, how we actually make a conscious effort to address this, opposed to just putting it on a mandatory training type of thing.
And I think that's an absolute valid point, Haris. So one of the reasons I got interested in, or the Patient Association got interested in epistemic injustice, is looking, so we have a free phone helpline, like you know, that takes calls Monday to Friday. And looking at the types of calls we receive, a lot of them is around where I believe that patients haven't been listened to. And I believe that patients aren't being treated as equal partners in their care. And that got me doing my own digging into a hole, how do we do this? So as an organization, we developed our principles of patient partnership. And I think they're really good. We did them with patients and with healthcare professionals. But then I was looking at these principles and thinking, well, yeah, these are great. But actually, if this level of, and our theory of change then looked at what needed to be in place so that we could have patient partnership in both the design and delivery of services, but in the but also in individual consultations. So people will call that shared decision making. But if you have a situation where somebody is holding more power than the other in that conversation, then you're never going to have shared decision making or patient partnership. So Haris, just coming back to you, because thinking about that really good point, in your personal experience or that of your colleagues, or when you were on patient panels before you started your medical training, do you have any examples of where patients felt that their voices were disregarded?
So I also now chair the National Network of Youth Forums. So I work with 60 NHS Trust youth forums across England. And I remember it wasn't a young person, but it was actually the lead for a youth forum telling me that they were told the youth forum creates too many problems and identifies too many problems in the healthcare system. Therefore, the organisation wants to shut it down. And for me, I was like, well, that's the exact point. Clearly, you're not doing something right if they're identifying problems, and you shouldn't shut it down. Another example of where a young person said to me they weren't being listened to was, it was a young person with chronic fatigue syndrome, and the healthcare professionals didn't understand it, the nurses didn't understand it, nobody seemed to understand it, because it's really hard to be diagnosed with chronic fatigue syndrome at a young age. And it was the type of thing they were told, oh, they're just lazy at school, oh, they're not actually trying, they miss the healthcare appointments because they just couldn't be bothered to come in. And it actually requires some knowledge and some empathy from healthcare professionals to be like, you know what, I'm not going to put their appointment as my first one in the morning because they do have chronic fatigue syndrome. And I always talk about how we can work in partnership with our patients, give partnership, power, and give them permission. And I think that's the type of thing of working in partnership. You know your patient, therefore, why don't work in partnership to them to actually create a bit of a personalized package of being like, you know what, when works for you. It's similar things. What young people say is, my healthcare appointment's always during school. Why? They can't, they don't want to go by themselves half the time. They want to go with their parents. The parents have work. There's amazing schemes that hospitals like Alderhay do of having appointments before and after school. So it's thinking of things like that, of how we can really delve into the barriers and slowly break them down. Because it's not the type of thing that's going to be solved overnight. However, I think there's great pockets of work happening. It's really about spreading those pockets of work and learning about them.
Yeah, no, completely. And Dan, I want to come back to you because thinking more generally, and I know that a lot of your focus is on depression and mental health, but in more general, how does epistemic injustice affect the relationship between the healthcare professional and the patient? And can it lead to misdiagnosis?
Yeah, I mean, it absolutely can, right? And given that, it affects the relationship badly. So something that my colleague Javi Carrell has worked on developing is this idea of pathocentric epistemic injustices, right?
Okay, you're going to have to explain that one.
I will. So we can obviously think of situations where someone's credibility is downgraded because of their gender or race or age, right? And these are important sources of misdiagnosis or mistreatment, right? So there's, for example, research that shows that Black people's reports of pain aren't taken as seriously as white people's, right? So those are really important. Those biases are a really important source of epistemic injustice that can lead to misdiagnosis. But there's also this idea of pathocentric epistemic injustice. What does that refer to? Well, basically that people with illnesses can be targeted by specific biases, right? So for example, doctors and people in general might have a sense that someone who's just gotten a diagnosis, or someone who has a particular kind of diagnosis, will be particularly emotional maybe. So they can't be taken as seriously as they would otherwise, right? Or it might be that being someone who has a diagnosis, you're not able to have the right kind of objectivity, the kind of objectivity that doctors think, or sometimes at least think is necessary to get to what we consider knowledge as opposed to just belief, right, or feeling. So it is a really big problem, and I think it doesn't just affect diagnosis, it affects every aspect of healthcare. Because how are you, for example, supposed to figure out if a treatment works properly if you're not taking the reports of the patient seriously along the way, right? So there are issues, for example, around how doctors, in a very kind of well-intentioned effort to provide evidence-based care, might have this quite thorough statistical knowledge about how a medication is supposed to work. Such that if a patient comes to them and says, well, this medication isn't working for me, it's actually making me feel really bad, it's not unusual, or there's research that suggests that quite often doctors might respond, well, I think you just need to carry on this for a while longer. Because that's what the research shows. It shows that you need to take it and keep taking it for it to work. And that means that while that can be true, right, in a kind of statistical majority of cases, it creates these risks for people to fall between the cracks that can become quite big, especially when doctors aren't able to take what patients are telling them about their health seriously.
Yeah, no, absolutely. And you made me think of an article which I will find and we will put it on the chat. And it was an article written by a GP about a more elderly woman who was put on numerous different drugs, which actually made her feel, and she was in her 80s, and it made her feel much sicker, and she was kind of confined to bed, and they ended up having a really important conversation about what mattered to her with the family present. And they took her off a lot of those drugs, and she managed to live a good life. And it brings me to the conversation, and Haris, that conversation about how do we get to a point where, you know, notwithstanding, and this isn't about us taking away the healthcare professionals' obvious professional knowledge and experience, but how do we get to a point where that question about what matters to you, because I think it becomes the part of any consultation that we have with a healthcare professional.
Oh, oh, that is a hard question. Can you repeat the question?
Yeah, so no, and it is a hard question. So in your experience, have you had consultations or interactions where the person that's working with you is really focused on what's important to you?
So actually, my own experience of having depression, my GP has always been really focused on what's happening to me. She wasn't like, oh, this is what's happening with, it's just other issues in your life. You're a med student, of course you're stressed. That's one people get a lot. They were actually like, you know what, this is real. This is what you're facing. And why, sometimes I go back to why was I able to fight for myself in this? And it's frankly because I knew the system. However, my grandparents are first generation immigrants. They don't understand English that well. And when it was a simple thing a few weeks ago of they wanted to order some more heartburn tablets, they had no idea what they're doing. They called the GP. The GP was like, "You're doing this wrong. Do it on the app." My grandma doesn't even know how to use the clock properly on a phone, yet alone the NHS app. We we seem to be making it easier for the majority, but harder for the minority. And I think that's really what does epistemic injustice mean for me is we're doing wrong for the minority. It might be fine for the majority of patients. However, we just marginalise this small group. And to beat those barriers, what can we do? It's a small things, and this is what I think about in my experience as a medical professional, that we, as part of our medical degree, we got to go to a school for disabled people and spend a day there and play wheelchair basketball and wheelchair football, which was really fun in electric wheelchairs. But when I reflect on what it actually taught me is their experience and actually spending time with them, that there's certain things that we don't think of as an able-bodied person. We're not able to do the same things. Simple things like access of someone going to school is I've heard stories of a young person with incontinence and the school, I always use this example, the school didn't give them a toilet pass, so they just have to hold it. Like, what type of justice is that for a year 7, year 8? Is that the type of thing we want to be leading on? But it takes, I think someone did put in the chat, how it shouldn't all be on healthcare professionals or something. I agree it shouldn't be. We should encourage patients to fight themselves. But I think there's a certain bit of knowledge that we need to use amazing people with lived experience to start teaching people and break down those barriers and be like, this is actually the problems I face. This is how you can understand me, and this is how, if you get a patient 5 years down the line like me, is how you can help me.
Yeah, it's something about, I used to work in children's hospice care, and there was something for me about legacy and the legacy of the learning that we did every day. But after a child being with us or a child dying, it was, what did we learn from this? What did I learn? How can I bring this forward and make sure that legacy of my learning is coming with me all the time? So you're always questioning yourself with humility and compassion. So Dan, you're part of the EPIC project down in
That's right.
University of Bristol. So can you tell us a little bit more about that project?
Yeah. So it's actually a quite large project. So it's funded by the Wellcome Trust, by a quite big grant, which has been able to fund this cross-university project. So we're based at Bristol, Birmingham, and Nottingham, and then we have some international collaborators. And what we're trying to do is to firstly better understand how widespread and what kinds of epistemic injustices occur in the context of healthcare. So we're doing that through a number of case studies. My case study, as I think I might have touched on, actually, I'm realizing that I did that before. My case study focuses on silence in the context of depression and bipolar, and trying to understand kind of in what cases silence is a sign of epistemic injustice and in what cases it isn't. There's other case studies that are looking at epistemic injustice and psychosis in young people. Case study looking at epistemic injustice among cancer patients. So we're kind of trying to work with these concrete cases to develop a better understanding of the kinds and spread of epistemic injustice, but then also kind of try to figure out, well, how can we make this concept more useful for people to really home in on what is the sort of injustices that people encounter? How can how can we develop this concept in a way that people can use it to kind of, when they experience an injustice, be able to say, well, this is an epistemic injustice. I know this. And given this, I know that this is what I could be doing or what I should be asking for, or where I should go, right? Um, and then we're also working, and that touches on the kind of third element, which is amelioration. So how can we address epistemic injustice? And I should say that we are just in the first year of the project, so we don't have answers to all these questions yet, but we're working towards them.
So, well, if you don't have answers, and I get that you're in the first year, are there any key findings or insights at this stage that would be helpful for patients and healthcare professionals on the line to consider in their interactions as?
Yeah. So if we think particularly in terms of, so there have been quite a lot of strategies kind of argued for as means of addressing epistemic injustice. I've mentioned some of them already, and you guys have touched on some as well. So for example, sharing stories, right? And having platforms for sharing and saving and developing stories is really important. And that's, of course, part of what the Patients Association provides, right? A kind of opportunity or a platform for people to be able to share their stories and for those to co-constitute or co-produce resources that others can use. And that's really important, right? Because one of the important kinds of epistemic injustices that have been identified are the ones that stem from the kind of rigid framework of what's sometimes called the medical model, right? Or what we could just broadly call like the language that doctors use. And that language is really important and good to better understand how we can treat illnesses, especially on the biological level, right?
Yeah.
But they're often not that good at capturing what it's like to be ill.
Yeah. Yeah, no, absolutely. And I think, Haris, I'm going to come back to you. I'm going to try and not ask you a hard question this time. I have so many questions I want to ask. So I think that medical model is that Dan referred to there, where we are sometimes treated for the disease or the condition that we have. And as a patient association, we try to be above disease and condition because I think it's all around communication. So and you talked about the really good interactions that you've had with your GP. I wonder, how do we get to that kind of more social model that looks at what matters to you? What is the outcome you want here?
So I think we do a medical model a lot as it works for the doctors, and I think sometimes it becomes second nature. Like now, I don't even realize I'm talking in medical terms. It just happens. So I think that's one of the issues that doctors actually don't realize that they're talking in this medical model and not actually looking at the social aspect. And I think having interdisciplinary teams is one thing that really helps this. How we have social workers, mental health professionals, community healthcare workers, and other non-medical staff in that team to really start to draw out those social skills, because I admire doctors and they have 10, especially GPs, they have 10 minutes to do an appointment, and what the appointment actually addresses is probably not the core issue, because quite a lot of it is social issues, I've realised. So having that interdisciplinary team really helps. And having that shift to patient-centred care. What I hate is we have 10 minutes for an appointment and you can discuss one issue in that appointment, because that issue is normally not the issue. There might be, this patient might have chronic pain, but what is the core of the issue? Have they been fobbed off by every other healthcare professional? And the reason they've come here is they want to be referred onwards. I think we're always taught to say at the beginning of the consultation, ask an open question. And we do this thing called ICE, which is patient's ideas, concerns, and expectations. But I think we should start asking the patient, what do you want to be the result of this? Where should we go to actually have that shared decision making properly? And it does come down to the education side of how do we start to combine it into the education. How do we get to what matters to patients? I think also for younger patients, for patients who can't advocate for themselves, for patients who don't understand English, is getting that family caregiver involvement. And I think that's something we don't do enough of, is we don't involve the whole family. And there's an amazing project that was done in Bradford of the doctors were accusing, you could see the type 2 diabetes rates and type 1 diabetes rates were really high in Bradford. And it's because there's an obesity epidemic. But it took one doctor to get to the core of the issue, that it is the Asian diet. And what that doctor did, they didn't send everyone to refer everyone to a gym. They didn't give everyone insulin and some drugs. They actually got the hospital to buy an allotment and taught the grandparents how to garden. And that is really getting to the core issue, rather than us saying, okay, this is not, we're just treating a cause rather than the core symptom. And I think that's what we need to get, is by involving everyone, including the patient, we try and we actually address the core issues.
That's a lovely example, Horace, because I think there's something about there's not something. It's about working with people, not doing to people, and understanding how communities and cultures and the intersectionality of who we are as people, because we don't fit into any, we're humans. We don't fit into tiny lines. We fit into the complex of life.
Can I jump in?
Yes, please. I was going to ask you to.
Yeah, because I think Harris has highlighted two really interesting things, and that's kind of the collective aspects of medical knowledge and the material aspects of medical knowledge. And since the last bit really touched on the collective, I think it's worth stressing that something that's really important to try to address epistemic injustice is practicing and creating opportunities for solidarity, right? And what we often do in Western medicine, but also kind of science in general, is we kind of frame these hero narratives around particular individuals. And that makes it seem like the ideal of knowledge, or the ideal of the pursuit of knowledge, is this single strong person who's figuring out what's wrong. And they often then impose that on other people as well. So you, the patient, should know what I need to know, or you should know what you need to tell me. And that precisely kind of blocks or obscures the importance of getting a lot of people involved. And really the fact that even though it might sometimes look like it's this individual who comes to knowledge, knowledge is something we produce together, right?
Yeah.
And I think that's especially important, like Haris says, in situations where there might be some communicative difficulties that a patient might have.
Yeah, no, absolutely. Absolutely. I've so many questions and I'm trying to pull together the questions in the Q&A as well. So, and some of the questions and some of the comments in the chat are talking about patients not being listened to, and that sometimes, you know, Haris, you talk about your training and how you're trained to ask a question. But that's okay. But you may ask that question, but you actually don't listen to the response, so you disregard the response, which is epistemic injustice. What advice, and Dan, I'm going to come to you first. What advice would you give to patients who feel they're experiencing epistemic injustice?
It's a tricky one. Because I guess part of it relates to what I said before. So I think on the spot, like you do get frustrated, you do get angry when you're not understood, right? Or maybe you just get really sad, right? And it can be really hard in those situations to then find a way to creatively kind of reframe what the doctor didn't get. And maybe you're also you're seeing that, oh no, I've already spent 8 minutes of my appointment. I need to get to the point now, otherwise I won't be heard. And sometimes I guess all you can do is go away and try to find someone to talk to help you figure out how you can get past the obstacles that you're seeing, right? How can you frame this issue in a way that will get taken seriously? But of course, the problem there is that a lot of us don't have those sorts of relationships where we can do that, that someone who we can go to and say, hey, this is what happened to me. Could we kind of work to figure out how we could how I could avoid this in the future, how in my next appointment?
Yeah, no,
And
that's
it's really
helpful.
hard.
Yeah, Haris, is there anything you want to add to that?
So for me personally, I think it's about asserting your needs, that you don't be afraid to actually speak up about your needs and experiences. So use those I statements. I remember saying, like, I feel like my symptoms aren't being understood. Can we discuss this further? Basically telling them, you're not on the same page as me. How can we actually get on the same page? And also, I think medical appointments are the most overwhelming things ever. There's thousands of things to remember, and then half the time in the moment. So make a list of all the concerns and questions you actually want to address,
Mm.
and be like to the doctor, excuse me, I don't think this has been addressed. Can we work through it? And the other thing is, if you really think that your healthcare professional isn't helping you, then it is your right to get a second opinion. That there's nothing stopping you from doing that. If you don't think health professionals helping or understanding what you're actually going through, or just completely misinterpreting the whole point, it is your right to go, is it for the next point, is it all right if I see someone else? Or is it all right if I see another doctor who might understand you and might give you a different perspective?
Yeah, yeah. So we've just launched 2 resources on our website, 2 animations around shared decision making and patient partnership principles. And we're moving more towards creating animations because I think that in a way they're more accessible. Is there something in the way that information is shared by the healthcare system that can make injustice happen?
Yeah, if I can start. So okay. I mean, both in how it's gathered and shared, right? Um, because so I mean, we can think of the case of Martha Mills, right? To see how even in a particular instance, there's a lot of how important it can be to share knowledge and how often it's not shared, right? So I was
Sorry,
just
Dan, can
reading.
we just before you go into that, sorry, I'm interrupting you, but Martha was a young girl who died, just maybe to give a bit of a background to the audience that may not have heard, and we are very supportive of Martha's parents' call and the implementation of Martha's rule, which is on our website.
Yeah, and Martha's mom, I don't know how to pronounce her name, Mary Mills, maybe.
Yeah, that's
She
right.
wrote a really powerful article for The Guardian about this. She works at The Guardian, so she's a really good writer. Um, and she was describing how doctors just didn't keep her in the loop about what was going on. In fact, they seemed to actively try to conceal knowledge from her. And that's another kind of epistemic injustice, right? That relates to this, the hermeneutical aspect I was talking about earlier. So, I mean, these things happen on the ground, that you don't get the knowledge you need, or that information is concealed from you. And of course, I mean, this is also a structural problem. So different knowledge isn't shared across the NHS. So it's not, if you switch GPs, or if you go to you might expect your next GP. Actually, Harris will probably know more about this than me, so I don't know the specifics, but I know that knowledge isn't appropriately shared across the NHS. So when you go and see your next doctor, they might have no knowledge of what happened to you before, and that puts a lot of burden on you. Every time you go and see a new doctor, you might have to rehash your whole medical history, and that's exhausting, right?
Yeah, and we hear that regularly from patients through our focus group work. That bit about services not being joined up together and having to tell your story again. Sometimes your story is a very painful story to tell. Haris, is there anything you want to talk about, the kind of tools or resources that we could have for patients to help patients better understand, better communicate, but also healthcare professionals and how they communicate with patients?
So I think what can help healthcare, I'll go for healthcare professional first. What can help healthcare professionals is actually sometimes taking time out your day to talk to a patient as a person, not as that 10-minute appointment. And the reason I say this is I really get jealous of nurses, and I'll tell you why. Because nurses have so much more time to actually sit and get to know a patient, and they get to know their life story in detail. They get to know what's happening, and it's kind of why I love being a med student. Is I don't actually have anything to do half the time. I can just sit there and talk to a patient and find out about their life. So I think that's one thing in a doctor's busy schedule. If they just take a step back and talk to a patient, it makes such a difference. I think what they can also do is let read into shared decision making, because realistically, I don't think a lot of doctors, particularly older ones, know what shared decision making is. They know it's a concept and they know it exists and they know they should do it, but how often do doctors actually practice shared decision making? And I'm going to mention, Dan, you mentioned disjointed health records. I think it's something the NHS is trying to address. That it's all like on West Yorkshire ICB, we had our patients tell us that they hate it. So we've got a chief digital officer who's working to create that shared care record across. And I know all integrated ICBs and integrated care board. So I know loads of integrated care boards are now looking into how they can create a shared care record across their patch. And how can patients advocate for themselves? I think, first of all, I'll break down. First of all, we've got the patients that can really speak for themselves, that were like me and were part of a youth forum. And what can that type of patients do is there's certain biases, and you mentioned what would be biases in data collection. It's simple things like medical research, which I think why patient and public involvement panels on medical research are absolutely amazing, because often they're homogenous studies that focus on just one demographic. They might focus on middle-aged men, they might focus on younger people, whereas we're giving these drugs to a whole range of people and we're not fully accounting for diverse experience. So how in medical research are we actually collecting data that represent population? And I think if you can, join your PPI group for your university and try and get involved, because that's one way you can really fight injustice on a level. And I think the other part is a lot of patients who I've spoken to have really rare or marginalized conditions, and they could be there'll be 3 people in the UK that have it,
Yeah.
and there's not robust data supporting the diagnosis and treatment. The doctors will often dismiss it of the patient's experience, give them another condition, and it's that type of thing. I always think for those patients, contact an organisation. There's rare diseases organisations that really help you. And I think for me, it's always that networking side and that peer support as well. That there's so many good patient advocacy groups out there now. There's so many, and even relying on your friends who might have had similar experiences or family members who had similar experiences, of talking to them and be like, "No, I've just experienced this. Have you seen that?" I think it's the whole package that needs to be created to address this. It's not going to be a one size fits all model. It's going to be things patients can do, things that we need to, as patients, start advocating for and telling educational institutions that we can, and then some actually solid policy changes to incorporate shared decision making into actual policy, and also incorporate patient voice a bit more into policy.
You answered. Well, you started to answer my next question, Haris, which is no, fantastic. We're just starting a piece of work to develop resources around patient preparedness. To try and help address that issue, because we regularly hear about communication that is not accessible and is not written. But my next question was, what policy changes could help reduce epistemic injustice in healthcare? And Haris, I'm delighted that you mentioned shared decision making, because that is something that we've been asking for, and patient voice and that partnership. And it's been in the chat and in the Q&A around how do we co-produce things together. Dan, what other policy changes do you think could help reduce epistemic injustice?
Yeah, it's a good question. I guess often we tend to think about this, or in our work so far, on a fairly abstract level. But so, because like that is where these biases often sit. They often sit above policy. But there's of course loads that policymakers can do as well. Harris has kind of touched on the importance of time in the context of healthcare, right? This is again a tricky issue to address, but I think if we start to think differently about how medical knowledge is generated, and there's already moves in this around this in the NHS. There's already requirements in mental health research, or a big push at least to involve patients to make sure that research is co-produced. I lost my train of thought there a bit. Oh, so yes. So regarding changing the way we think about knowledge, right? So kind of making a clear space for patient knowledge in the healthcare system and on the level of research. And that might involve articulating that, well, we contribute different things. Because I think a trap is sometimes that we try to beat scientists at their own game, right? And that ties us into knots, and it just makes things complicated. Again, I mean, I think about the case of Martha here, where you get obviously patients who are doing research on their illnesses, and then they come to doctors and they bring that research, and that can presumably be really useful in some cases. But it might also put the doctor's kind of shackles up and thinking like, I'm the medical expert here. And it's important to kind of think tactically around how can I bring my knowledge in a way that really reflects my expertise. We need to try to make room for that on the policy level. Exactly how that should be done, I'm not sure about. But something else just I want to stress is making processes simpler. And that's something that we don't necessarily need to make decisions about on the kind of national policy level. That can be done on the NHS level, right? And
Yeah.
without having Parliament intervene. I think that's really important. And again, gets at some of the stuff that Haris talked about, where we need to think about, well, how can we make it easier for people who don't speak English as a first language to understand the process, to fill out forms, and to express their needs in a way that others will understand and take seriously, right?
That's a really interesting point, and we get a lot of calls to our helpline where people are fine, and I kind of describe it as wayfinding. I talk about, you know, as an individual, and I feel like I know the healthcare system, and yet I will find it difficult to find my way around the healthcare system. And I spoke with a healthcare professional that I really value, and she talks about curiosity, understanding what's happening. How do we build curiosity into the culture of healthcare?
Mm.
I don't know if either of you have got a comment on how we might build that in. No, that's okay. It's just something that I think that, and it's come up in the chat and in the Q&A, something around that level of curiosity from the healthcare professional. We talk about it a lot, where people might miss their appointments, and trying to understand and not just disregard it and go, that's a do not attend, a language that I really don't like, but actually going, actually, I wonder why this person didn't attend. And, you know, it can be down to not having, we're doing a study at the moment on social inequities, and, you know, people talk about the cost to even just get to the appointment. The fact that maybe they don't have the confidence to be in the room, they're scared of what they might be told. There's lots of things. And I think if we had that curiosity about each other, it would be a different environment.
I think that's right. And I think it might be important to, and I don't know exactly how we talk about, but talk about different kinds of curiosity, because I think doctors already think of themselves as curious. And they probably are curious. They wouldn't be in the profession if they didn't have a sense of curiosity, probably. There's just a question of, I think, whether they're curious about all the right things, right? And they probably aren't for a variety of reasons, right?
Yeah. Yeah, no, completely. Okay, I'm really mindful that we're starting to come to the end of this, and I still have a load of questions. And I think somebody's just put in on curiosity, open questions, perhaps by allowing silence to be followed. Sometimes it is the silence in the room that's really important, isn't it?
I'm obviously going to agree with that. And something that I've been hoping to be able to mention is that it's important. One very practical way of navigating epistemic injustice can be to just find find the opportunity to be silent, right? To just take a breath, or maybe kind of practice a metaphorical silence. Like, listen, I can't explain this to you now. I need to go away and find a way to do this better. Um, yeah. I think it's really important not to assume that just because someone isn't talking, that they're being subjected to an injustice. We need to have both room for talking and sharing and room for people to be silent. And it's those two things together that are the foundation of epistemic justice.
Justice, yeah, yeah. Haris, what do you think about silence?
I love silence. We're taught to give the patient a golden minute, but sometimes I don't often think the golden minute is enough, because when you're having a really good and the golden minute is a minute where you don't interrupt the healthcare professional. And from the patient side, I've actually now noticed doctors doing this. But sometimes you're human, you're required a bit of time to think. Not every I know for me personally, when I'm talking about my story, sometimes it's quite hard. Sometimes I actually just want to take a break, think about what the core issue is. instead of the healthcare professional interrupting and being like, so what's the next thing? I think that's the bit about curiosity. I think healthcare professionals are genuinely curious to get to the cause, but I think the way we're that we're taught about curiosity is different to what patients want. And I think before it ends, that's one of the policy changes I would say is about having a curriculum update to really ensure that we have that combined in, because we all have to do mandatory training in the NHS. It's every NHS professional's bane of their life at the start of the year. However, it does work. People might think it's pointless because we need to really start dissecting those unconscious bias going cultural competency. And why don't we have mandatory training on epistemic humility? I think that'd be an amazing start for NHS England to do, is actually really recognising epistemic injustice and epistemic humility is a thing, and this is how we can address it.
Yeah, absolutely. So you have 1 minute left. What's the next what's the next big step, do you think, to achieve justice?
That's an on-the-spot question.
It is an unknown spot. But I think the curiosities come out quite strongly. And I think, Haris, your conversation about shared decision making becoming more of the norm. I think, Dan, you talking about that silence and understanding more about that silence. And I think is education the next big step?
I think it probably is. And I think part of a kind of key part of education will be to talk about, precisely like Haris suggested, epistemic injustice. Kind of embed this concept in the care system, in how both patients and doctors understand their interactions. Because the fact is that biases pervade our lives, right? Some biases are good, some are bad, and we need to get a better understanding or just awareness of how they affect our ability to kind of be epistemic agents, to obtain, maintain, and share knowledge, right?
Right. So that is the next big step, I think, is that we acknowledge our biases. Haris, is there anything that you want to add to that?
I think it's education for both patients and healthcare professionals. As a patient, I like fighting for myself, but I think we need to educate other patients on how to fight for themselves, what your rights are as a patient, and what actually to do when you go to a healthcare appointment. And it's 10 minutes with your GP. What should you talk about in those 10 minutes and how to prepare yourself before? It can be quite overwhelming. For healthcare professionals, I think we're really seeing a change in the NHS on how healthcare professionals are with other roles coming about, which hopefully will free up a lot of doctors' time. We never know. So really using doctors have slightly more time and the time's being freed up. What are we filling that with? Should we be filling that with them trying to address systemic issues and things like epistemic injustice within their clinical specialty?
Brilliant. Well, I'm sorry, but we've just run over and I'm going to have to call this to a close. But Dan, Haris, thank you so much. I learned so much on that. I have so many more questions and I have so much more to go and read. And Dan, the best of luck with everything that's going on with the EPIC. We're glad to be working with you. We look forward to attending some of your sessions as well. And Haris, safe journey back to the UK. Thank you for joining us at 3 o'clock in the morning. Once again, it's been a pleasure to listen to you. And I'm going to call this to an end. Thank you all very much.